someone I realized this morning that I've known for 24 years. Amy's worked exclusively in the field of Alzheimer's and related dementia disorders for over 30 years. Her experience ranges from adult daycare and home health to working as the original activity director in the very first dementia-specific assisted living in the country, and later as executive director opening a building in West Orange, New Jersey. Ms. Matthews also worked for the Alzheimer's Association Greater New Jersey chapter for 14 years, providing both professional and community education and training. Amy currently specializes in professional training and community education. She also provides consulting with professionals and families on best practices and helping them create a plan of care for the future. Amy was also a caregiver for her grandmother who had vascular dementia and considers this her greatest experience in terms of understanding how these diseases affect families and how families reach out and interact with professionals. So it is my pleasure to introduce to you Amy Matthews.
Good morning, everybody. And I just have to say right off, I'm a visual thinker. So when you said there's a survey monkey waiting, I just picture the monkey waiting to collect everybody's surveys. So thank you in advance for filling those out. The monkey's going to be happy. What we're going to talk about today is what exactly is dementia. And I always say that dementia is probably one of the best known, most used, and least understood terms out there. But I have to say that it's really among the most important terms to understand. So hopefully we're going to clarify what it means and take a little bit of the fear out of it, if you will. So first thing is, dementia itself is not a disease. It's merely the category of symptoms. So when you think of the term dementia, I want you to think of it almost like we think of cancer. I'm not comparing the two at all, but cancer is not the disease. It's the category of symptoms. And the key is the first question you ask when you hear cancer is what's causing it? We want to ask the same question when we hear the term dementia. What's causing it? Why is it happening? Dementia is not a normal process of aging. I think a lot of us remember that term senility, that we firmly believed when you get old, you get senile, you get forgetful, it's normal and it's going to happen to everyone. But dementia is different. It is not a normal process of aging, and it is more than just memory loss. So there are criteria to be diagnosed with a dementia. So it doesn't just encompass all forgetfulness. The criteria include the first one, which is where confusion or memory loss is severe enough that it actually interferes with a person's ability to carry out their daily activities. So what exactly does that mean? I'm going to use some examples that I think we're all familiar with. One is if you've ever lost your keys, which I'm just going to generalize and say, I think most of us have done that at one time or another. When you lose your keys, it's frustrating, but you can usually sequence events or retrace your steps and figure out where you left them. Whereas if a person has something more serious, and I'll use Alzheimer's as the example, as that is currently the most common disease that causes the symptoms of dementia. Someone with Alzheimer's actually loses the ability to sequence events, so they can't remember where they began, making it impossible to retrace your steps. And as disease progresses, a person may actually have the key in their hand and not be able to identify what it's for, so they continue searching for the key. So it prevents that person from moving forward with the next thing in their day. And then the second criteria is that the deficits have to affect at least two of what we call the four core mental abilities. So the first mental ability is recent memory, or what we most commonly call short-term memory. And short-term memory for all of us is a choice. If something's important to you, then you do whatever works, whether it's writing it down, repeating it multiple times, whatever works for you to take it from short-term and commit it to your long-term memory so that you can then recall it later. But if it's not important, we let it go and it never gets into long-term memory, and that's what we call forget. With a disease like Alzheimer's, that one of the early effects of typical Alzheimer's is that people lose the ability to take any new information, even if it's important, like I need to take this medicine, lose the ability to take it from short-term and commit it to long-term memory. So that person, no matter how many times you repeat yourself, cannot commit that to memory. We call it forgetting, but if you think about it, forgetfulness doesn't really capture it, because to forget something, it had to be in there to begin with. We're saying with effects to the recent memory, this person can't take that information and commit it to long-term memory. So there's nothing to retrieve. Language is the second core function. And by language, we mean receptive language. So basically how people understand written or spoken words. If someone has a disease like Alzheimer's and their language is affected, which it tends to happen relatively early, you start to see changes. A good example might be if the person goes into a restaurant and they can read the menu perfectly clearly, say it out loud. There's hamburger, there's meatloaf, there's roast beef, everything sounds so good. And then the server says, what would you like? And the person goes, I don't know, what do you have? Because reading is a long-term skill that's still intact, but now the word and what it cognitively represents begins to fade away. So even though the person read it perfectly, it's not connecting with what it actually means. The third is executive functioning. And executive functioning is basically our safety awareness, our ability to plan and follow through on a task. And executive function is often where families see if there's something more serious going on with a person. If someone was always very safety conscious and now they're leaving the door unlocked, or the person is burning pots on the stove, where that would have never happened because I always triple check the stove to make sure it was off. That's usually when we have an idea that there's something more serious than just what we call basic forgetfulness. And then finally, visuospatial function, which is a term probably not a lot of us have heard of, but visuospatial function doesn't so much have to do with your vision, but really how your brain translates lines, symbols, and maps and places you in the environment. So a good example might be when you go in any public building, by the doors, there's always an evacuation route map, which just has a very rudimentary drawing with a red line that shows where you are and how to get to the nearest exit. If somebody has a deficit with their visuospatial function, they can look right at that map and have no idea where they are within the building, let alone how to get out to safety. Visuospatial function you can also see in driving, where people aren't so much mindful of what the lines on the road means or the symbols in the traffic signs. So to give an example of how at least two of these things might be affected, let's take receptive language and visuospatial function. So maybe somebody's driving and they come upon a stop sign. It says stop, but their language is impaired. So they're reading stop, but it's not connecting with I need to stop the vehicle. However, we should still be okay, right? Because we still recognize that universal shape, that octagon of the sign itself. But if the visuospatial function is also impaired, it's not connecting at all with I need to stop the vehicle. So the person goes right through. So again, to qualify as a dementia, the memory issues have to be severe enough that it actually interferes with a person's ability to carry out their daily activities. And it has to affect at least two of those four core mental abilities. And I'll stop for a sec just to see if anyone has any questions, if that makes sense. All right, I guess we're good.
Yeah, no questions so far.
Excellent, I must be doing my job. So the causes of the symptoms of dementia. So typically causes will fall into two categories: neurodegenerative diseases, which are things like Alzheimer's disease. And we'll talk about those in a little more detail in a moment. And then what we call other conditions. Other conditions are typically physical in nature, which is important because if they're physical in nature, there are often ways that we can manage or even eliminate those. The reality is most people have multiple causes of the condition. So they may have a neurodegenerative disease, but also some of these other physical conditions that can actually magnify the confusion, disorientation, which is why it's so important to get an accurate diagnosis. So diagnosis itself, I'm going to ask you, and you think about it for yourselves, and then I'll generalize a little bit, but how accurately do you think they can diagnose the cause of the symptoms of dementia out of 100%? And I'll tell you what I typically hear is a lot of people either actually don't even use words. Some people just go like this. Some people may say 20%, some people may say 50%. But I think generally folks rely on what we hear is the only definitive way to diagnose Alzheimer's is a biopsy at death. That's Alzheimer's, correct. That's the only 100% accurate way to diagnose it. However, getting what we call a full geriatric assessment, they can be 90 to 95% accurate at determining the cause of the symptoms of dementia. Remember, often people have multiple causes. So through a series of evaluations, it's not a test, it's not a half hour in the doctor's office. A full geriatric assessment, if nothing else has been done prior, can take up to full 2 days to get a complete look at the person. And often it's a team approach. So it's maybe a neurologist, it may be a geriatric physician or specialist. You may have a geriatric nurse practitioner, a social worker. So basically you have people looking at the whole person. And through this series of evaluations, so medical history, psychological, cognitive, blood work, scans, social history, who was the person, who are they now, what's different, medical history, what in this person's background could they have had that can affect memory, including things like Lyme disease, which we don't always think of, or were there people in the family that may have had a dementia? By looking at all these things, they basically begin to rule out those other conditions, which again, we said are typically physical. So these are things that we can find through testing. And I'll talk about those in more detail as well, and can now much more specifically hone in, if it is a disease, which one it may be. So it is important to get that accurate diagnosis. We don't want that word dementia to prevent us from finding out what's actually going on.
Amy, we've had a couple
And
questions
yep.
come in, if that's, I think
This good time.
Okay. I think one of them you just mentioned you're going to talk about, and that's
Okay.
and that you just kind of addressed. Is there a test to take to get a baseline reading of brain activity? Is that something you're going to mention?
Well, and basically that's a great question. So I think that, and you correct me if I'm wrong, Liz, because you probably know this better. I want to say 2011, it became a standard practice that anyone over 65, the cognitive test is part of their annual evaluation, their annual physical. And this is, and not all doctors do it. That's why I'm saying this, but that's what is the protocol. And this kind of gives us the baseline. And that's just a cognitive, that's just the tip of the iceberg, but it does help kind of give a baseline of what someone's normal functioning is in their brain. Does that kind of answer that for you?
I mean, I think that's a good
start.
If I were the person, answering that, but they can. Now, the other questions are diseases. So does having Lyme disease in the past increase your risk of dementia? And then
let me address that real quick. That's a great question. And remember, dementia is the category of symptoms, right? So it's not the disease, and Lyme can fall into another condition because Lyme does affect memory. So that's a good question. And they don't always think to look for Lyme's disease, especially in certain parts of the country where it's not as prevalent. I think in the East Coast, because it tends to be more of a risk here, that often is part of it, but it's something you definitely want to ask the doctor to make sure they rule out Lyme's disease.
Okay, and we also have medications that cause dementia. Someone heard that statins can cause dementia, and are there any supplements to prevent it?
And I'm gonna hit that in other conditions a little bit. I always need to preface, I'm not a doctor, nurse, or pharmacist, because I'm married to a lawyer, so I have to say that stuff. But I'm going to try to answer that as best I can. I can't tell you specifics, but as to can medications cause the symptoms of dementia?
Okay, and the brain scans, do they show the areas of the brain that are deficient, like the language area?
Excellent. Brain scans right now, I don't think it's out in the general public accessible yet, but I know there's an MRI that is so specific it can begin to show early signs of brain changes. Certain scans, and they typically, the most common I hear, MRI, PET, and CAT scan, can show areas of activity and inactivity. And yes, by looking at certain regions of the brain, they may be able to see what area is more affected. And also there are certainly outward signs of that, like language. You can tell when someone's having difficult with comprehension or processing. But currently there's nothing, one scan that will specifically show you, and if I may, I'll use Alzheimer's as the example. You can't see the plaques and tangles yet. What they tend to look at is you can see areas of activity and inactivity. You can also see atrophy or shrinkage in certain areas of the brain. And certainly you can detect things like stroke or TIAs, trans-ischemic attacks, by lesions on the brain. So yes, they're using those scans, but this is also why this full diagnostic workup is important, because they really need to look at everything. It's not just the brain. The brain's the center of everything, but you really want to look at the whole person to see what we can rule out as other causes.
Okay, and I think the last question for this section, we have more questions coming in, but if you could go over executive function.
Certainly. So executive function, again, is your safety awareness, your ability to plan and follow through on a task. So executive function, and this is really dependent upon the person. I always preface that, because these diseases, if somebody has a neurodegenerative disease, really don't affect any two people the same. It's as unique as the person themselves. Some people have always had very good safety awareness, and I'll throw myself in there as the example. I always lock every lock on a door. If you've got 30 locks, I will lock every one of them, to the point where I've actually locked my husband out when he's right behind me, because it's so automatic. Now, if I stop doing that, if I stop paying attention to the locks and I'm leaving the door open, there's something going on with my executive functioning, because that is not normal for me. If someone never had good executive functioning skills, and there are people who don't, they just don't have good safety awareness. They're the ones who are, will walk out of the room and leave the stove on and smell it burning and say, oh, that's right. Or never lock the doors. Then that's not something you might see in that person. But for many, executive functioning, it really is that safety awareness. And add to that the visuospatial piece, safety awareness, like you look at that evacuation route map and find your route out so you know how to get there. But if someone stops paying attention to those things, then there's an issue with their executive functioning. Does that answer that for you?
I mean, for me, it does. But no, we have a lot of great questions coming in, and I encourage people to keep asking them. But
we'll move on to the next part here, because we might get some of your questions here. So let's talk about the causes, right? Neurodegenerative diseases that cause, and you'll see I'm using that term, symptoms of dementia, because I want us to really stop kind of thinking of dementia as its disease. It's not. It's a category of symptoms, and we need to know why they're happening, what's causing them. So go back to our Latin: neuro, neuron, or neurotransmitter, messenger. Degenerative means destroy. So basically, these diseases are progressive. They get worse over time. Typically, the older the person is at onset, the slower the progression tends to be, because your body just doesn't work as efficiently as it does when you're younger. The younger the person is at onset, which is classified as 65 or younger, older onset is 65 or older. The younger the person, the more rapid the decline tends to be. And they're degenerative. They are literally destroying the brain. And in most of these diseases, they are fatal. We don't tend to think of these diseases as terminal illnesses, I think most likely because of the amount of time it can take to progress. So Alzheimer's, for example, can go anywhere from 3 to 20 years. And so we don't kind of feel that, we feel that we have so much more time with these because they progress so slowly. So just to go through these briefly, Alzheimer's, as we said, is the most common disease currently that causes the symptoms of dementia. And it's most notably marked by a progressive decline in memory and ability. There aren't really plateaus where a person doesn't change. It's a continuous kind of progression. The first thing we typically see with typical Alzheimer's is short-term memory issues. So that's where you may get repetitive questions. Someone saying, you never told me that, and you did, but remember, it can't get into the long-term memory to be retrieved later. We also, as disease progresses to the end stage, it is currently the sixth leading cause of death, although I think COVID changed that a little bit among adults in this country. It was the fifth leading cause. And we don't associate it as a cause of death, but your brain controls every function of your body. And if someone progresses to the end stages of Alzheimer's disease, it affects the parts of your brain that regulate breathing, that regulate your heart pumping, that allow you to have movement, to walk, And that's why you hear things like pneumonia, aspiration, and heart failure, because the brain has kind of cut off those mechanisms. The second most common is vascular dementia. And this is typically caused by mini strokes or TIAs, trans-ischemic attacks. So what are those? Mini strokes are like a pinprick to the brain. By itself, it really does minimal damage. And honestly, people can have had a mini stroke and have no idea they ever had it. This doesn't mean you have vascular dementia, by the way. The difference is with vascular dementia, these little strokes are continuous. So one, it progresses a little different than Alzheimer's and presents a little different. We said Alzheimer's is a precipitous decline. Vascular dementia is a stair-step decline. So somebody seems okay, but they're having these continuous mini strokes. Eventually, all these little pinpricks do enough damage that the person seems to suddenly present with a loss. Might be cognitive, might be physical, or it might be a combination of the two, really depending on where the strokes are hitting the brain. So you see plateaus where you don't see that with Alzheimer's. Also different between Alzheimer's and vascular is people with vascular tend to have what we call intermittent short-term memory. It'll come and go. So a person with vascular can learn and retain new information, but it'll come and go. So you may talk to someone, they're right with you, come back later, they have no recollection of the conversation. But then you come back later again and the person goes, that's right, we were talking about that this morning. Dementia with Lewy bodies, depending on what you read, is either third or tied for second most common. And basically it looks like Alzheimer's and that you have this progressive loss in memory and loss in ability. But at the same time, from early in the disease, it also looks like Parkinson's disease. So with dementia with Lewy body, memory may not be the first change you see necessarily, but you tend to see physical things that look a lot like Parkinson's. And people may have rigid arms or legs, which often makes a person very unsteady on their feet and at great risk for fall. Lewy body dementia also has often what we call flat affect or no emotions. So it can kind of be hard to read the person's face. Dementia with Lewy body, about 50% of people with that disease also suffer a sleep disorder. So when we go into REM sleep or dreaming sleep, our body's actually blocked from movement. If any of you have ever woken up in a fall dream where you go like that, that's your body unlocking. 50% of people with dementia with Lewy bodies lack that blocker. So when that person goes into REM or dreaming sleep, they actually can become physically active. So there's a lot of daytime drowsiness that has nothing to do with boredom or lack of stimulation or day-night confusion. It really has to do with they can't get good rest, because anytime the person begins to go into deep sleep, their brain and body become active. Frontotemporal dementias, these are typically the least common types, but basically their primary area of damage is your frontal lobe and your temporal lobes. These areas of the brain, among other things, control personality, behavior, mood, and because of that damage, this makes these types of diseases actually among the most challenging in any setting, whether someone's at home or in a care setting, because they tend to have very unpredictable and even aggressive behaviors associated with them. And I say unpredictable for a reason, because with Alzheimer's, vascular, even dementia with Lewy body, often people don't just act out for no reason. There's always a reason, and often there's lots of subtle cues when someone is kind of revving up, if you will. But the challenge with frontotemporal dementias is that it comes out of nowhere. A person can be laughing and enraged without warning. Also, frontotemporal dementias typically, not always, typically affect younger people. So average age is between 40 and 60, which also means they tend to progress much more rapidly. And I keep saying there's different ones under that frontotemporal category. So Pick's disease, if you've ever heard of that, is one, tends to affect younger people. Huntington's disease, which is hereditary, would be classified as a frontotemporal. Wernicke-Korsakoff's, which is a dementia associated with alcoholism, falls under frontotemporal. And then if you've ever heard of mad cow's disease, the human form of that is called Creutzfeldt-Jakob, which also falls under frontotemporal. And then finally, mixed dementia, which most commonly is where a person has two neurodegenerative diseases simultaneously. Most often we hear of Alzheimer's and vascular dementia, and that's harder to detect, obviously, because it can present more like one or the other or just a combination, but they may suspect it when somebody has cardiovascular issues and that progressive loss in memory and ability. So that's kind of a picture of the most and least common diseases right now that we tend to see. And I'm going to jump to the other conditions, and then we can open up for questions again. Remember, we said other conditions are typically physical in nature. So where, with the exception of frontotemporal dementia, which progresses very fast, no matter how old the person is, commonly it's younger folks, but it can be older. When we see a sudden change in mood, memory, personality, or behavior, that is not typical of disease progression, especially in an older person. Things come slowly. So sudden change often indicates something physical. Now, some of the most common physical causes of the symptoms of dementia among the elderly in particular, medications, which is one of the questions, right? So medications, the average amount of medications a healthy senior takes a day is between 7 and 14. Now, this also includes vitamins and herbal remedies, which we do need to keep account of because anything you put in your body affects it. But if you look at a lot of the common medications, so like someone asked statins, yes, they can cause memory issues. Do they lead to a disease like Alzheimer's? To my knowledge, there's no evidence that it can cause a disease. Can it cause the symptoms of dementia? Yeah. But if we're able to figure out which medicine it is, and if we're able to find an alternative that doesn't have issues with memory, then that person may regain full cognitive function if that's the sole cause of their memory issues. So medications are important. And if you look at most medications, including the medications we most commonly see for these diseases, Aricept, Exelon, Razodine, they all have side effects of memory loss. So what is helpful for all of us is to periodically have all your medications, including vitamins and herbal remedies, and even over-the-counter short-term remedies, reviewed. You can have it reviewed by your doctor, or a really great way, if you get your medicines at the same place, is your pharmacist, because they typically have all that information accessible and can advise. Also advise you, even if someone has a cold or allergies and they take other medications that can cause memory issues, go back to the pharmacist and say, I'm going to get this Claritin or NyQuil. Can you just tell me quickly, do you think this may have any adverse effects that I should be aware of? Clinical depression can cause the symptoms of dementia. By clinical, I mean chemical, which can be detected through blood work. Now, depression in the not so distant past was mistaken for Alzheimer's. But depression is manageable. It is not easy. The older a person is, the harder it is to find the right medicine or combination of medicines at that time to treat it and manage it. But it's worth that push, because depression unmanaged, and depression also often accompanies the diseases we just talked about, can actually magnify the confusion. So treating it, managing it can in essence kind of lift a layer from that person. Vitamin deficiency, right now it's B's, niacin, thiamine, and B12. And often people get put on B12 supplements. And I just want to caution, please don't run out and ramp up your vitamins. Always talk to your doctor first. But these vitamins and how we process them can help and affect memory. Certain tumors or infections of the brain, blood clots pressing on the brain, anything that puts pressure on your brain changes how it works. If that is the sole cause and they're able to take care of it, then that person may regain full cognitive functioning. Metabolic imbalances that aren't being managed by medicine, thyroid, kidney, and liver can cause issues with memory. And malnutrition, but dehydration. Dehydration is the #1 reason seniors end up in the ER, and it can happen under the best of efforts. Your body doesn't crave as much fluid as you age. And right now, the current folks that we most commonly see with the diseases, they weren't the generations that push drink 8-ounce glasses of water a day. You have people who get nervous if they drink before they go out or go to bed, they'll have to go to the bathroom 300 times. So dehydration typically manifests itself as a suddenly the person is more confused and more disoriented than is usual. So sudden change, mood, memory, personality, or behavior isn't typical of most of the diseases we discussed. So we always want to rule out physical reasons first. And then one of the biggest ones, UTIs, urinary tract infections, don't typically manifest themselves as you think. It's not that the person necessarily has to go more or less, or that it may be more concentrated. But what we almost always see is all of a sudden, the person gets more confused and often more agitated. So we want to always rule out UTIs and dehydration. And now stop for a sec, Liz, if we've got some more questions.
Yes, and I think some of these you addressed, but I will go through, can taking Advil PM at night increase symptoms or progression of disease? And I think you kind of said people should talk to their pharmacist about that. Is
Uh,
that, or,
Always talk to your doctor. And I mean, anything that is sedative, a sedative like a PM, one thing you want to watch for, if it's whether it's for yourself or somebody you care for, is it actually can increase the risk of fall. So if someone's trying to get up to go to the bathroom, so you really want to ask the doctor before giving someone that or taking it, and just make sure that there's no counterindications. Can it rev up disease? Not to my knowledge. I've never heard anything to that effect. It's a temporary thing, but you just want to be careful because it often does increase the risk for fall.
okay, how about having a condition such as a bipolar disorder? Does that predispose one to dementia or, as you said, symptoms of dementia?
Excellent question. Um, to my knowledge, you can't directly link it to a disease, bipolar. But one thing that we have seen, and I say we meaning in the field, being in this for over 30 years, oftentimes, even if bipolar was managed and someone does develop a disease like Alzheimer's, it can kind of unlock it, meaning we need to find different ways to manage it and to make sure it's being managed, because certainly it can magnify confusion, disorientation, agitation, things like that. But to my knowledge, there's no direct link between bipolar and Alzheimer's disease. Can it cause the symptoms of dementia, right? Because those are remember the criteria. When someone has memory issues severe enough to interfere with their ability to carry out daily activities and affects at least two of the core mental abilities, yeah, it can cause symptoms, but that's where ideally if we can manage it.
Okay, so now severe concussion in the
Mhm.
past, can that cause symptoms of dementia in the future?
Very good question. And yeah, I mean, I think that's why we see all these studies and now paying such close attention in sports where people have a tendency to have head injuries and concussions. Yes. And there is a link. And by severe concussion, really, they kind of classify that as when there's a loss of consciousness. They have linked concussion, severe concussions, to a higher risk of developing Alzheimer's later in life, and also frontotemporal if you're in a field where hitting the brain against the front of the skull can damage that frontal lobe. So definitely, and I think that's why we see so much attention nowadays to head safety.
Okay, so now epilepsy as a brain disorder, does it cause symptoms of dementia?
That's a great question. And that's not my area of expertise. I know it is a neurological disorder, disease. So it obviously it affects physical abilities. It can affect, I think, speech, but to my knowledge, it doesn't. I don't know. I'm not gonna answer that definitively because I don't know. I've never heard it as a direct connection to disease, and I'm not sure that it can affect. I guess if it does enough damage, it can certainly have symptoms of dementia associated, but it's not my area of expertise.
Okay, if a person's parent had dementia, is that a factor in that the person can develop a disease of dementia as well, or a dementia type
So
disease?
excellent question. And I'm gonna specify that a little bit, if I may. For Alzheimer's in particular, again, which is the most common disease that causes the symptoms of dementia. If a parent or sibling had Alzheimer's disease, it does increase the risk that you could develop Alzheimer's disease in particular. It is not definitive, though. It doesn't mean you'll get it. And genetically, there are genetic tests. They've identified two genes, PSN1 and PSN2, presenilin-1 and presenilin-2, that are associated with young onset Alzheimer's disease specifically. And by young onset, it means 65 or younger. So I believe it's presenilin-1. If you do have that gene, it is deterministic that you'll develop Alzheimer's, and often it's in the 30s, 40s, or 50s. It is very much less common. And in families that have that, it's evident, if you will. And then PSN2, if you have that gene, it is deterministic that you would develop it. Typically, it would happen in the 50s and 60s. So again, it's that young onset, but with the PSN2, it's not necessarily linked to multiple members of a family getting it. And it's not that very, very young, 30s, 40s, 50s. So in that sense, I think that kind of covers it generally.
Okay, do you consider normal pressure hydrocephalus a neurodegenerative disease? It causes symptoms of dementia, but it is treatable. It's also
excellent question.
diagnosed.
That's an awesome question. And actually, I'll say NPH, normal pressure hydrocephalus, is actually would technically be considered under the other conditions, right? And if it is treatable, because it can't always be alleviated, but if they can put a shunt in, that's the most common thing you hear, to drain the fluid from the brain, then often that person can regain functioning. So just a quick, what you tend to see with NPH, and if a person's not an expert in issues that cause memory loss, they may not necessarily look for it in an adult. We tend to think of it with children, but NPH tends to present with a stooped posture, a shuffle walk, urinary incontinence, and a slowness of response. And in terms of slowness of response, people can answer the questions and it's typically correct, but it takes time to get it out. If the pressure can be relieved, often the posture becomes upright, the urinary continence ends. However, the slowness of response doesn't always end, but that would be those other conditions. And yes, ideally, if it's manageable, then that person can regain.
Okay, how about Menieres disease?
Menieres disease, which is hearing. To my knowledge, there's not a link with that. It certainly causes other things. It can cause issues with dizziness. It can cause I'm not gonna say lethargic, but not wanting to do things because it's invasive. It can affect sleep, which all affects our memory and our ability to function. So if there are ways, and I know there are exercises, I don't think there's a cure for Menieres, but I think there are things we can do to minimize it a little bit.
Okay, and you had mentioned Aricept. What are your thoughts on it, and does it really slow the process?
I will give you the educated answer, but again, I'm not a nurse or doctor, but Aricept, Exelon, and Razidine are all in the same family of medications called acetylcholinesterase inhibitors. So basically what these drugs are meant to do is they inhibit or hold back those enzymes that are destroying the messengers in the brain, right? The connections. And in essence, turbocharge the ones that work so they connect. They are not meant to stop, slow, prevent, or reverse. They are intended to slow the presentation of symptoms. So it slows what you see. It's not stopping the trajectory of the disease. They are not meant to improve. They're meant to, to know it's really working is to see no change in the person. To know it's really, really working, and I don't suggest this, you stop it and the person tends to decline and they don't tend to come back up to where they were when it stopped. And then Namenda, which is a different class of drugs, and in its clinical studies and the way it was meant to be given is with Aricept, Exelon, or Razidine. Namenda actually works with different receptors in the brain, and it's meant to help allay some of the behaviors you see. And the best, and I know you didn't ask about Namenda, but I'm saying it anyway. The best description I ever heard was from a doctor. If you remember back when TV stations actually went off air at night and there was just static, these diseases are like static in the brain that's so pervasive you can't focus. And if you can't focus, you can't function and you get frustrated. So Namenda is intended to quiet the static, to enable someone to better focus. So they're not regaining skills lost, but they're better able to continue to use the skills that are still left. If that kind of answers that.
Yeah. I think we have 3 more questions related to this section.
Okay.
And can diabetes contribute to symptoms of dementia?
Excellent question. And diabetes is listed, type 2 diabetes, as a risk factor for developing Alzheimer's disease later in life. Not the type 1, but type 2 is listed as a risk factor. So again, can we say it directly causes it? No, but it does put one at higher risk for developing Alzheimer's, in particular later in life.
Okay, and you mentioned there's a blood test to diagnose clinical depression?
Correct. chemical imbalance. So it's just something, again, when you're talking with your doctor, and the reality is, and this is nothing against anything, but doctors only find what they're testing for. So we want to become educated, vocal partners in the healthcare relationship, because you are, nobody knows you or the person you care for better. And a doctor can only do with what he or she sees in the moments of the visit. We need to fill in the blanks. So that's one of the questions you want to make sure we ask. Has depression been ruled out? And there are depression scales, but also blood work can help us understand chemical imbalances in ways that we may be able to even things out.
Okay, and then last one for this section, and we'll still do questions. So, can you explain the connection between the urinary tract infection and dementia?
I can't tell you technically why. UTI's infection it's an odd one, because like I said, it doesn't typically present traditionally. And you also want to be mindful if someone has a history of urinary tract infections, which some people do, men and women, more common in women. But UTIs can be common in someone with Alzheimer's or related dementia in particular, and I apologize to be graphic, but in women in particular, if somebody wipes from the back to the front, that can make them more susceptible to urinary tract infection with E. coli, which is harder to treat. But for whatever reason, you definitely see it come out in behavior changes. Often a person is more agitated and confused. But I don't know why that is so much, but I don't laugh. I'm thankful, because UTIs present in those ways, and typically we can find it quickly when we know what to ask to make sure we rule out a UTI and we see that sudden change. Don't assume it's disease.
Okay, I think for the sake of time, how about we continue
Certainly.
on, and then we'll bump the other questions.
And this is just a video, the facts and figures of the Alzheimer's Association for 2021. I'll stop there because I'm not going to do an ad, but I think that's just a kind of an important visual just to see how prevalent it is. And now we're just going to kind of go over some of the risk factors. And I think that alludes to some of the questions we had in the last section. Again, Alzheimer's is the most common disease currently that causes the symptoms of dementia. The single greatest risk factor is age. By 65, about 1 in 8 people develop it. By 85, about 1 in 2. But it isn't something that everybody's going to get. But if you just think about our aging population, other risk factors identified to increase the risk of developing Alzheimer's later in life. So we said those young onsets, in particular, young onset where a person can develop Alzheimer's in 30s, 40s, and 50s is 100% hereditary. The one where people can develop it in their 50s and 60s isn't necessarily hereditary, but they've identified that PSN2 gene. But for late onset Alzheimer's, aside from age, history of heart disease, history of stroke, high blood pressure, high cholesterol, type 2 diabetes, and obesity, all have been shown to incrementally increase the risk of developing Alzheimer's later in life. And you see my graphic here, that's for a reason. Normally when I do this presentation in person, I watch people going, oh, got it, working on it. Take a deep breath. One thing we also know is that if you have these things, it doesn't mean you're going to get Alzheimer's. It can put us at greater risk, but we also know identifying these things can help us find ways to minimize. Ideally, I'm not going to say it absolutely will minimize it or prevent you from getting Alzheimer's if you manage your numbers, sugar, weight, cholesterol. But it does help us ideally potentially reduce the risk of developing Alzheimer's later in life. You also can kind of see from these risk factors that there is an emerging link between heart health and brain health, which makes sense, right? Your heart is the engine. And if the engine isn't firing on all cylinders, then this doesn't get what it needs. So that's why we see that kind of link between the heart and the brain. So what can we do? And there are things you can do to promote brain health. And I'm saying that carefully. There are so many ads, there are so many books, 100 ways to prevent Alzheimer's. There's no way to prevent it. If you're going to get the disease, unfortunately, you're going to get it. But we can promote brain health, and things we can do that can help not only promote brain health, but promote heart health, and ideally help us live better, longer lives. While there's no direct prevention for the neurodegenerative diseases that cause the symptoms of dementia, there are things we can do to promote a healthy brain. And I'm going to go back. That also includes being mindful of those other conditions, those physical things that can cause the symptoms of dementia. Knowing those helps us be that active vocal advocate with our doctor and an equal healthcare partner. So 10 ways to love your brain. And this comes from the Alzheimer's Association. Break a sweat, exercise. Exercise increases your blood flow, right? And if you increase that, then your brain's getting more oxygen, more blood. It's good for everything. Hit the books. Increase your long-term knowledge. The more we have to pull from, even if God forbid someone does get a disease like Alzheimer's, the more that's in there, then the more we have to draw from as disease progresses, that stays intact. Hit the, oh, I already read that. See, I got to pay attention to myself. Butt out, I'm not being rude. Don't smoke. If you smoke, try to stop, because smoking's not good for your lungs. So that affects oxygen. It's not good for your heart. It's not good for your body, which means it's not good for your head. Follow your heart, watch cholesterol, watch, get your heart checked, watch your numbers. Heads up. That goes back to that question about head trauma, right? If you do anything that could potentially involve a head injury, riding a bicycle, skiing, wear a helmet. It's been shown to help protect the brain. Fuel up right, so diet, right? That helps us watch our weight. It helps us, and now there's all kinds of diets out there. Probably the most prevalent one you hear associated with brain health is the Mediterranean diet, that really does promote full body health, but has been shown to help promote good brain health. Catch some Z's. Sleep is important, and you're increasingly hearing studies about sleep deprivation and the risk of developing even diseases, but certainly it affects our ability to remember things. It affects our ability to function. Take care of your mental health. It's imperative, and I'll say it again because depression has been classified as a mental illness as well. It's not easy to manage, but we need to, because it has been mistaken for memory issues. But if somebody also has mental health issues and develops a neurodegenerative disease like Alzheimer's, then that can magnify the effects if it's not managed. So take care of your mental health. And I'll say, if you're a caregiver, you're absolutely the most important person in the caregiving process. So please take care of your own mental and physical well-being. Buddy up, socialization. We know that, right? If anything has taught us that, it's been this pandemic. The isolation was particularly hard on the elderly and families caring for someone with Alzheimer's or related dementia. It is imperative to be out and about and talking to people who share your memories, and to socialize, because when we isolate, we decline, any one of us, mentally and physically. And stump yourself. Do things that make you think differently. It's, some people say, crossword puzzles. Now this Wordle is all over everything. I haven't gone there yet. I haven't gone down that rabbit hole, but, do things that stimulate your mind and make you think differently. So what do I do now? So like we said, it's 3 types of stimulation that promote healthy brain aging. And I'm also going to tell you that even for people with these diseases, keeping someone physically, socially, and cognitively engaged will help maintain that person better, longer, regardless of the drugs. But the key is to continually push folks to do as much as they can for as long as possible. So physical activity, like we said, it can be minimal exercise. Park 3 spots further than where you usually park. Take the stairs every now and again, whether up or down, as opposed to the elevator. Just walking. Walking is one of the best exercises there is. Helps your heart health, helps your brain health, helps maintain your weight, helps everything. Social activities. It is imperative to engage in social activities. Even if you don't like people, try to get out a little bit. Because it does make a difference. And cognitive stimulation. So I just want to preface here, there's not a single thing to do. Some people say if you do crossword puzzles, you won't get Alzheimer's. No one can ever say that directly. But here's the thing. If you can't spell, that would be me, then crossword puzzles have no therapeutic benefit for you. In fact, it just frustrates you. Do something you enjoy. But what do we mean by make you think differently? Learn a new language. There are languages like the Asian dialects, Aborigine in Australia, that actually are processed from the opposite hemisphere of the brain than the English language. The English language comes from the left hemisphere of the brain. Aborigine, many of the Asian dialects, which are symbolic, come from the right hemisphere of the brain. Play an instrument, listen to music. Music is processed throughout your entire brain. So even if there are areas of damage, and one of the most amazing things we see in individuals with Alzheimer's or related dementia, or if you know someone with a stammer, often people have the stammer when they speak, but can sing perfectly clearly. Music can unlock memories and in essence can give back speech, because we've seen folks who are not so verbal, but they can sing every word of a meaningful, familiar song. So music is a great tool. I always like to ask this in person because I can see, but I'm going to ask anyway. However many people are right-handed, your right hand is guided by your left hemisphere. Try doing things left-handed. You're actually switching how you think. However many people are left-handed, I'm a lefty. And I always like to say we're already in our right minds, right? Because your left hand is guided by your right hemisphere. Try doing things right-handed. If you're ambidextrous, awesome. You're already working both sides of the brain. And another couple ways real quick, stop using speed dial. When you start training yourself to remember phone numbers again, you'll be amazed at how quick it comes back, but that is stimulating your brain. If you're used to going a certain way and you always go the same way when you go someplace, switch it up. Or as I say in New Jersey, wait 5 minutes and there'll be a detour. But that again, it stumps your brain. It makes you think and makes you think differently. So you're exercising that muscle. And believe it or not, now I'm done. So now we can open it up for your questions through the Q&A or the chat.
Okay, so one of the early ones that I missed was, can areas that are deficient in the brain be remediated?
That's a great question. And I think part of that would come down to that diagnostic process again. So areas that are deficient, why are they deficient? What caused the deficiency? But there is cognitive therapy, and there's lots of information about that you can access online that may help strengthen areas of the brain. And I know that there are a lot of physical therapy techniques, believe it or not, where they actually work to retrain the brain and create new connections. So if it's not working in one particular place, and there was one radical therapy that I read about a while ago, where if you've lost use of your left side, so to speak, and we're trying to retrain it to get it back, they actually restrict your good side so that it makes your brain create those connections and work that.
Can tinnitus contribute to dementia?
Is that tinnitus?
Tinnitus, yeah.
I think it.
Hearing, yeah.
You can see symptoms of dementia, but can it cause a disease? No, not to my knowledge. But again, if you think about it, if it is so disruptive in your head that it can affect your focus and your concentration and potentially your sleep, which all affects our ability to process things. If there's a way we can alleviate or minimize that, then ideally we kind of can regain that stuff.
Okay. There are a couple questions about heart surgery. One is that if you've had open heart surgery, are you at greater risk of symptoms of dementia? And,
excellent question. Go ahead, read the other one too.
Oh, the other one was, can heart stents or cleaning out the carotid arteries stop vascular dementia?
That's a good question. So let me do the first one first. Less the heart issue, unless there's deprivation of oxygen to the brain for a long period of time, more the older a person is, that's your English there, the older the person is, the longer anesthesia can stay in your system. So for an older person, anesthesia can be in the system for up to 6 months to a year. People can still feel the effects with like brain fog and whatnot. So that's something to be mindful of. And one of the things they should be talking to you about if it's an older person getting open heart surgery. Can open heart surgery cause a disease? I've never heard that there's a direct link. However, another thing we see, and I'm going back to anesthesia here, is that when we've had folks who have a disease already or may have it and didn't know it, it seems to rev up the process a bit. It seems to progress that person forward a bit. But I've never heard that it is a cause of. And the other question about stents and stopping vascular dementia. Vascular dementia is a progressive degenerative disease. So if a person has it, I don't believe it's going to stop it, but stents can certainly minimize the risk of stroke and a heart attack, right? So, and stroke can have symptoms of dementia, but it may not progress if the person's only had the stroke, if that makes sense. So the damage stays where it is. It's not going to progress like vascular dementia, but because vascular dementia is a disease, it's not going to stop it, but it would help certainly minimize the risk of strokes or major stroke and certainly minimize risk of heart attack.
Okay. At what age would you suggest starting to see a geriatric physician?
I think for the age insurance suggests is 65. You can correct me if I'm wrong there, Liz. It's a very good question though, because if someone has young onset, honestly, typically the diagnostic process will start with our primary care physician, but not all primary care physicians have a good understanding and knowledge base of these diseases and other conditions. So that's where we still may suggest, if you have real concerns, go to a geriatric assessment center, because that's where we see more of it and that's where you see more of the expertise in it. But 65 is the insurance age. That's when, and often insurance, which you have to check with your provider, would cover up to 80% of the cost of a geriatric assessment.
Okay, I think this question is probably refers to an individual, but the thing that comes to mind is sundowning. Are there triggers that bring about times of more confusion or delusions?
That's a great question. And if I can break that apart a little, you're going to laugh, but sundowning is actually my absolute favorite behavior. Sundowning itself actually has nothing to do with the sun. So I like how you said that is at particular times of day. It's individual specific. If a person's up all night, they may actually sundown in the morning. So it's a particular time of day where someone is more tired, agitated, and confused. Sundowning is an interesting behavior, and not everybody goes through it, but it always has a start time. You can literally set your clock by it, and it typically has an end time. And often sundowning is environment specific. So the keys are to, when you see sundowning, it's already started. So if you see it every day at 5 o'clock, that's when the person is at their, we call it the witching hour in healthcare. Then it didn't start at 5 o'clock. It probably started at 4:30, 4:15. You want to get the person before it starts. If it always happens in the kitchen in front of the window where they see cars going by and I need to get home, then that's the environment that it started in. So once we identify the start time, the end time, and the environment, we can start to come up with ways, ideally, to minimize it. And that's going to be unique to the individual as well. For some people, maybe it's, you always want to keep them clear of the area where it typically happens. So if it's in the kitchen, then we want to steer them clear of that. Sometimes something as simple as going out for a car ride at 4 o'clock around a few blocks and coming back home can get you through it. Sometimes offering the person, if they start to get more confused after lunch, offering a nap. But be mindful, because environment's important. Don't let someone have a nap and have the room completely dark, because that's disorienting and it can feel like night. And sometimes nothing works with sundowning, but what I do promise is as disease progresses, it will phase out eventually. But sundowning, when you identify those things, can help. And nobody knows the person like you do. So I always say an advantage we have is, while the person can't necessarily tell us what's going on verbally, accurately, the person will show you everything you need to know. So trust what you see. You can identify those patterns. And once you do, and maybe documenting helps, then we can find ways to try to minimize or eliminate some of those behaviors.
So how do you talk to someone with short-term memory loss who is aware that they can't remember anything, like just being to the doctor or eating dinner? My mom calls me over and over again every night. Are there tricks to manage this?
Excellent question. And there's no single answer. So let me take yourself off the hook there. It's trial and error. Basically, ideally, whatever the person says is where you begin. It doesn't matter what happened before or after it. Because of the short-term memory loss, they're not going to remember that. And you want to focus on the emotion with which it's said. So if it's stressed and frightened, then think of words that are calming. Take your time. We'll figure it out. Or if they say, you know, when is my doctor's appointment? Well, I think we have another doctor's appointment in whenever the next one is. So start from where the person is. In terms of getting multiple phone calls, protect yourself. I might suggest getting another line and not answering it every time. Because you're the most important person here. And that also may be an indication if the person is living by themselves, that maybe someone needs to be there at that time, whether it's a home health aide or another family member, to help get the person through that period of the day that's rough for them, where they're constantly calling, because that phone is a magnet. But also I would suggest strongly that get another number so that you can protect yourself a little bit. You don't have to answer it every time.
Okay. What are the stages of dementia? Is being argumentative one? And do they move out of that stage? I think you've kind of addressed that, but.
Yeah, it's an excellent question. And I wouldn't actually even classify that as a stage. Here's what I'm going to tell you that you probably don't realize. Every single one of us knows what it feels like for moments to have these diseases. We all do. There's no new emotions. So put yourself in the person's place. Watch the person. He or she is going to show you everything you need to know. But aggression often makes sense. 9 times out of 10, it's how the damaged brain is processing the environment. So if the person doesn't always recognize us and has receptive language issues, so you're saying, I'm going to help you get your coat off, and you're walking with your hands up like this, that's going to do fight or flight. If I don't recognize who you are or what you're doing in that second, I'm going to fight you. Or if you say, I already told you that, and I have no short-term memory, you didn't tell me. Everything is in the moment it happens. So 9 times out of 10, aggressive behavior is a direct result of something in the environment. So whether it's the physical environment, the social environment, how we engage the person, how we talk to the person, and the emotional environment, how we support the person wherever he or she is. So be mindful of your body language, because these individuals have an exceptionally keen awareness of body language and environment, and can honestly read you faster than you open your mouth to talk. So if you're frustrated and you're either showing it or it's coming out in your tone, that's what the person reacts to. Or there's too much going on in the environment, and either people get agitated or they shut down. Environment plays a huge role in giving the person with the disease back a sense of control.
I think one of the things you taught me early on, when we were in elementary,
in the trailer days,
yeah, is, can you tell people about therapeutic fibs? Because
yeah,
that was one of the things that I tend to share with people, that they find an aha moment.
There's lots of schools of thought on what's the right thing to say, what's the wrong thing. And let me first say, there's no right or wrong. It's whatever works in the moment, period. And the person you're connecting with is your guide, not anybody else. But there's schools of thought that you should always tell the truth no matter what. But here's the reality. If I say, have you seen my husband and he died, and you say your husband died, I'm going to relive it like it just happened. All the emotions, everything. And then I'm going to forget, and you're going to tell me again, and I'm going to relive it like it just happened. And we never intentionally want to do that to somebody. You should lie. Well, guess what? I always say, unless you're a politician, we've all got a subtle cue when we lie. You may not even know what it was, but because these individuals have such a keen awareness of environment and body language, they pick up on it, and you can break trust. And it's very hard to get it back with someone with no short-term memory. So what I advise is what we call therapeutic explanation. Therapeutic explanations are basically the truth, but not the whole truth. It's the truth for where the person is at that moment. So if I say, have you seen my husband? I didn't ask, did he die? I said, have you seen him? And a therapeutic explanation might be, I haven't seen him, but I'll keep my eyes open. That's absolutely not a lie. You just don't finish the thought. And that preserves a person's dignity. It addresses their emotion at the moment. And emotion remains accurate even when words don't make sense. If you always address the emotion, you're always going to have an appropriate response. But the best news yet is if a situation goes horribly, what I do promise you is the person with the disease is going to forget it, right? But if you don't let yourself off the hook for the interaction and you wear it, that's what the person reacts to. I go too far sometimes.
No, that's great. I think I think people need that permission to
Exactly.
explain things differently.
And if you can find a beauty in this, and I use the word intentionally, one, bad interactions go away. You have to let yourself off the hook, but also sometimes from this, we get to learn about people things we never knew because we have a benefit of watching someone relive their entire life. And in some instances, you actually develop relationships that would have never been possible if not for the disease. Not that you ever want that, but there are what I call beautiful moments. And the key is once we put all our plans in place, knowing the big picture and the trajectory of diseases, we need to focus on those moments.
There are a lot of individual questions here that I think for the sake of time, I won't read right now, but one of the things that came through was how would you go about getting genetic tests to check for possible types of dementia?
That's an excellent question. In terms of genetic testing, the school of thought typically is that unless there's a family history of it, and it tends to be on the younger onset side, it's not necessarily recommended to get genetic testing. I'll use late onset Alzheimer's in particular. Now, if we talk about Huntington's disease, that's 100% genetic. So there, if you've got Huntington's in the family, it's definitely recommended that everybody get tested. But in terms of a disease like Alzheimer's disease, late onset, they look at something called ApoE4. And if you have that from one or both sides of your family, you have a greater risk of getting Alzheimer's later in life, but it's not deterministic. It doesn't mean that you will. So learning that information, you're still living on the same what if as you age, right? Because age is the single greatest risk factor. So genetic testing isn't necessarily recommended, but certainly if you want to do it, talk to your doctor. And it's most advocated that if you do, go to a genetic testing center where you also have access to a genetic counselor, because you want someone to be able to explain what does it mean and what doesn't it mean.
Okay, let me just do, can high B12 cause bad effects? So a lot of these are here's an interesting one. Do vegetarians have less dementia?
That's a great question, and not to my knowledge. It's as they've always said for everything, right? Everything in moderation. We just need to make sure we're getting all the nutrients and minerals because, things like magnesium deficiency, potassium deficiency can all wreak havoc with memory. So we want to make sure we're getting all the important nutrients, especially as our bodies age and don't produce some of these things as efficiently.
I think you'll like this one. Coffee, good or bad? It doesn't say anything related to dementia, but yeah.
I love it. Anything in moderation. Just recently, there was a contrasting study. For a long time now, we've heard that actually coffee is good. And now we just heard one that it's bad. Anything in moderation, but talk to your doctor, talk to a nutritionist. I personally love coffee. So if it's bad, I want to be bad.
Is with types of dementia, is obsession with talking about sex common?
Excellent question. No, that can be more indicative. And again, I'm not diagnosing it, but when there's frontotemporal damage or frontal lobe, your amygdala, which is anger, fear, and sex in your brain, that part of your brain is damaged. That's where you can hear that kind of, or see that kind of behavior and conversation. So it's not typical of a lot of the dementias. That being said, sometimes there's also parts of people's lives and thought process that we didn't know of. And so sometimes as any of these diseases progress, inhibitions go down. So it's not necessarily a new thing. It could have been just what the person always thought and knew enough not to say. But when there's frontotemporal, that can, not always, not, it's not synonymous, but that's where you can see that inappropriate sexual language and behavior, but not common.
Have you heard anything with chemotherapy having long-term effect on brain health?
Yeah, I've never heard it and I'm just going to say, I've never heard a definitive study that will link it to a neurodegenerative disease, but yeah, I have certainly heard that, where people can get that brain fog and it can affect processing because it's, affecting your entire body. And if people can be in remission and come out of it, what I've heard, and again, this isn't my area of research or expertise, but that, ideally, once that's out of their system, they can kind of come back a bit. But yeah, it certainly affects your entire body.
Okay. I think we got most of the general questions. A lot of them are very specific and individual. So, but I do want to remind everyone.
I was going to say my email is on the last page of the handout too. So if you have questions, feel free to email me. And if I can answer them, I will. And if I can't, I'll tell you, because I'm married to a lawyer.
Well, thank you, Amy, for this great presentation.